Hi and welcome everyone. This is Manuel Lubinus. I'm the Chief Science Officer with MSU, and I'm reporting about the EULAR, the European Conference of Rheumatology 2024. Last time, I think you guys follow us with our reporting from GCOM, the Global Myositis Conference, back in, was about that March, where we were in Pittsburgh. You had a full group of MSU reporting from there with all the interviews and everybody else. So I think from this interview of rheumatologists, a general meeting is not necessarily about myositis, but this year I attended a meeting in Vienna last June. So we presented at MSU a poster on the burden of disease with patients' data that was only possible because you contributed to it and you are part of all these things we do for myositis. As you know, I'm also a patient with myositis. I have inclusion body myositis. So every time I can do something in the area of myositis to better understanding and better bring the perspective of the patient to the table, we are there. So I will introduce a little bit more about what EULAR is all about and what we learn in some areas of this topic. Thank you. So what is EULAR 2024? EULAR is a major rheumatology meeting involving healthcare researchers. I think about 14,000 people attend, including researchers, also patient representatives. So the focus here is to exchange information on all rheumatoid diseases and musculoskeletal diseases as well. And there are some myositis. This meeting there was not a lot of myositis, but there were some. And also includes like groundbreaking research, mostly from European labs, but as well from researchers in the US, like, Japan, Asia. So there is a lot of updates on disease management. The number of presentations basically can be quite extensive. There are probably more than 2,000 posters presented and reflect the breadth of research and the clinical work. One of the reasons I also like to go to these conferences is because the pair, which is basically the patient group, is very friendly. So it's a group that is very good to go to interact and connect with other patients as well from different rheumatoid diseases. So basically have a number of sessions, oral presentations, and a lot of posters. So we presented a poster. You can see displays of research. You can talk to different investigators, and of course do some networking at the same time. I have in the past presented oral. This time we had a poster presentation. As I mentioned before, about 2,000 posters are made here. So this time was in Vienna. Last year's time we were in Italy for this meeting, and I'm glad that I could attend again, and my medical condition allowed me to attend. So let's get and cover some of the topics. There's a lot of topics, as you can see, so I have to be very careful and very intentional about what I'm going to cover. But I have some solutions for you if you want to hear more about it. I again cannot tell you the whole thing for 4 days conference with so many hundreds of conferences on this one, but I will try to do my best. So let's go to the next slide. Another presentation that was very interesting here was the presentation on fatigue and pain and the unmet needs. So I think we discussed a lot of myositis about fatigue and pain, and I think this presentation from Dr. Van Tubbergen from Maastricht University in the Netherlands kind of got to the point discussing that. Recently we had as you know, a webinar on fatigue. So this was interesting data that was also presented here. And I think the main issue is that sometimes physicians don't really know how to deal with fatigue. Many patients have fatigue. I think 3 out of 4 patients actually are unsatisfied with the management of their fatigue, as well as pain. And fatigue is a critical symptom, often ahead of pain, you know. And but she tried to explain why is that. So I think she presented this kind of icons to show lack of visibility. Many times you cannot see the fatigue. You feel fatigue, but doctor cannot really measure that in a way. It's subjective in nature. Is that caused because you did something, or is just because it's the way you feel now? And because it's the way you feel now, it's also normalized, right? I always like to put the example of having a 20% battery. And with 20% battery, very quickly you get to 0% or 3% and everything is red. versus starting with 80 or 90%. So I think that's this normalization where we accept fatigue and the doctors normalize fatigue as something that is okay, but not really need to be treated, bring this misunderstanding about how to deal with this, right? It's being captured maybe, but it's really not acted upon or what to do. So I think that's a disagreement of what the doctor has a definition and what is a real physical fatigue and also psychological fatigue. And also pain can lead to fatigue as well, right? Muscle weakness, tired. So all those type of disease activity and fatigue are often not associated. You can have be in remission and still be fatigued. And what does indicate and how does the doctor look at that? So those are the factors where I think for us in the myositis sphere are very important because we really need to understand that. So, and we have many people attending the last webinar on fatigue, so I think this is important. She mentioned pain, of course, and one of the things that we need to understand about pain is that we need to know that kind of different kinds of pain. So understanding pain is kind of going through that and figure out what they are because they are created by a lot of different factors. So I think the simple way to figure out is something called nociceptive pain that is basically caused either with inflammation and is something that actually triggers the signal through the nerves and then you feel it. But there is no damage to the nerve. Now when you have nerve damage, for example, you have diabetes, often you have problems with neuropathic pain and you have different sensation of this type of pain, which is diagnosed as well. So that's a type of pain. Plus you have something else called the nociplastic pain. That is none of the two, but you know, this combination of all these different pains is certainly hell. So I think I put that little graphic here because it shows you once you have pain, there is nothing you can do, and you feel many times about pain, but we'll discuss that a little bit more. How is that used? I mean, we still use the scale to look at pain, and we'll discuss a bit more about some of the strategies on that in the next slide. So here I want to talk a bit more about the presentation from Dr. Yvonne Lee. She is a pain management doctor at Northwestern University who attended the meeting, and she presented some data on managing pain. And on one side was a bit depressing because, you know, not many new strategies are there, but she talked a bit more about kind of the degeneration of pain. And so most of this pain in most rheumatoid diseases is nociceptive, so that's actually happened because you have an inflammation or you have wounds, or like for example a rash in myositis in your skin or your muscle, and this is caused some type of receptor activation that is a non-neural damage, so it's not causing damage in the nerve, but it's actually transmission that goes either from your skin somewhere else that actually activates the receptors. And you know, this is like a train, so the fibers go from, let's say, your hands, go all the way to the spinal cord, and then it transmits to the brain, and then you experience pain. So it's always a process, and there is a transmission, and there are different fibers associated with pain and different fibers associated with this type of receptors. So another thing that she mentioned was, at least in rheumatoid arthritis, pain and inflammation are not always correlated. Some of those patients still have fatigue, they have problems sleeping, they have many problems as well. And there is also the nociplastic pain that is basically an amplification of pain that you wouldn't have otherwise. So this is also related to sensory signals, for example, light, sounds, that you become more hypersensitive to those, and that also can cause pain. And the abnormalities in pain perception. So it's a shift of the curve to actually experience more pain. And then she mentioned some data about emerging treatments for pain management. However, most of that was related to rheumatoid arthritis, even fibromyalgia. So the use of JAK inhibitors, I know that some of you guys have been using those. and some are better than others according to the study. It was difficult to know because the studies were not very conclusive. Some studies pointed in one direction, some in another. What I say is it seems to be some mechanism of action which is not directly related with acute inflammation on the inhibition. So the jury is still out on how this process works. She presented some of the old data from many things that have been used in the past and do not work. So I don't really want to tell you more about that because that part was a bit depressing. But I think the question is still more things need to be learned. And also in myositis, we still have to learn a lot of things about myositis and pain and the cause of that. And I will leave it at that. Thank you. The next slide was about improved self-management of pain. And that was a presentation by Dr. Christine Boot from the University of Twente in the Netherlands. And I think this is an important point that she brought. How can we as patients do more in looking at our self-style or self-management and take control of our condition, right? So I think it's important when we say we take control of our diet, but also empower the patient through education to manage the disease symptoms. I think that's an important part. She talked about sleep, so how kind of compartmentalize your sleep is important. And the term that she uses is sleep hygiene, so prevent all or nothing behavior, that either you are too active all the time or you are just getting enough sleep. So all those factors contribute. And I think that some of these are kind of common sense, but I think it's nice to see them written here. So technological aids like apps are actually helping now for people to have phases of relaxations, phases at work, kind of balancing, having that time for yourself or that time for being a mother, being a friend, socialize. So I think it's important in the management of pain because it's not thinking about pain. So I think that's interventions are very important. As I mentioned before, there are now 32 applications for monitoring, but many of those are not changing behavior. So I think they are letting you know symptoms, but not necessarily they are actually an intervention to actually change the way you do things. So I think that's an important part. She also brought some data about the virtual reality in pain treatment and how has been used. We'd like to hear more about that. So hopefully we can understand a bit more about how virtual reality works. As you know, there is a lot of advertisement about virtual reality in the meta world. And I think the final point that she made was how come all these factors are important. So, you know, like when you have toothache, most of the time you have toothache at night because during the day you are distracted or you are relaxed, but at night sometimes you are more vulnerable because you are thinking about pain and your perception and augmentation is different. So movement seem to help. So there is a lot of things that actually are part of that. So I would say that was an important lecture that I really enjoy. How can we actually do more for self-management of pain? So I think that's one I would like to keep. Finally, there was a topic in the conference that I thought was very interesting because it's also a changing area. So we talk about autoimmunity, but also there is a topic of autoinflammation. So what is autoinflammation? So you have your immune system, and what happens is sometimes there is a spontaneous relapsing inflammation in the absence of antibodies or even a cell response. So it's basically your native immune system responding as an autoinflammation. These conditions are many kind of genetic conditions, and they have been studied, but now we also kind of seeing them in a different context because we look at autoimmunity when basically your immune system, that means your lymphocytes, B cells, T cells start to attack your natural organs, right? Like in the case of myositis, start to attack your muscle, and then you have all those reactions, release of toxic cytokines, things like that. So this is something that is being understood now, that is actually a spectrum between your immune response, which is the antibodies, the adaptive response, and also kind of genetic factors. So there is a disease called ankylosing spondylitis, where seems to be some of these characteristics. And then you move more to the autoinflammation, then you have diseases like Crohn's disease, where you have some component that are genetics, and then less of a component with pure autoimmunity. So this is interesting because it's kind of understanding how can we control the immune system better in both circumstances. And I think one of the author was has recently also been involved in a study with MDA5, and that's what I thought was interesting, because the MDA5 autoimmunity and this syndrome that they characterize called MIPC, which actually is MDA5 with pneumonitis in the presence of or at the same time as the COVID pandemic. So I have to be careful with the language here. So they saw in this population in a town in England, which I think is pronounced Yorkshire, that was an increase on MDA5. And as you know, MDA5 is an autoimmune disease, part of dermatomyositis antibody, but in this case it's also they saw a cytokine storm of those patients and really severe lung disease, right? Interstitial lung disease. So they have autoimmunity, and at the same time seems to have some components of autoinflammation. So I thought that was interesting. That paper has provoked a lot of discussion because it was at the same time as the COVID was present, and was people also was being vaccinated, and how to understand the mechanism of action is something that is still to be clearly elucidated. But I thought that this part of understanding the inflammations and the spectrum between how your naive immune system reacts and how autoimmunity is produced is something I would probably see a lot of more work, and also based on different diseases. Of course, there is a lot more that came in these conferences, but I already kind of have 15 minutes allocated for this. So our friends of arthritis and autoimmunity, they have actually a site, and they have in the past have reported from EULAR. So I know Tiffany Reslich Robinson, and she is the CEO of AI, and they have been reporting on EULAR for a number of years. So they have more topics in the website. So you're interested to see more videos, including tapering and withdrawal syndrome related with corticosteroids, or advances on Sjogren disease, or even understanding and managing cognitive dysfunction in different rheumatoid conditions. There are many of those topics they are actually covered, some as short as 10 or 15 minutes, and some of them have more discussions about that in their group. So I'm going to leave you the QR code. It will take you to the YouTube video and you can see more. So I hope this has been interesting to you. Let me know if you have any questions or comments, and you can send this to us. Thanks, and have a wonderful weekend.